today. Qu'est-ce que c'est? Sorry. In making this decision, it is important not to lose sight of our goal, and to get to one or more follicles according to IUI or IVF, to choose the treatment according to the patient's age, ovarian reserve, cause of infertility, etc., to adapt the treatment during stimulation, to protect against complication, and to make the process simple and easy for the woman. And for all patients, it's very important to have the first step to make the right diagnosis, to be able to offer the appropriate treatment. And for that, you have done basic assessment, history, weight, age, duration of menstrual cycles, lifestyle factors, exams, pelvic ultrasonography, ovarian reserve, hysterosonography, spermogram, and also to identify patients at risk of OHSS and thrombosis. To continue, I would like to set out the guidelines followed by all doctors like good practice. In IUI, moderate stimulation for one or no more than 3 follicles. In IVF, stimulation for an average of 10 follicles. In both cases, monitoring cycles, triggering by HCG, and in case of IUI, preplanned sperm test to get at least 1 million. So, basic treatment. Here is a reminder of different kinds of gonadotrophin, urinary gonadotrophin or recombinant. You know that because De Ziegler spoke yesterday about that. Here's a reminder of different use. Between in IUI, between 50 and 100 units per day. In IVF, ICSI, and according to ovarian reserve. And for example, in PCOS, around 100 to 150 units. In normal responder, 150 to 225 units. And in poor responder, 300 units. And for some people, up to 450 units. The choice between HMG and RFSH is a question of feeling because no difference has been proved. And addition of the LH is debated except in case of hypogonadism. This is just a help for the beginner. It's not rigid, okay? But sometimes you can addition of LH in poor responders or in older patients, in cases where oocytes are dysmorphic, and in every case where the LH is under 1 unit during the stimulation. In case of IUI, I just, for unexplained infertility, etc., I just like remind you to that. But it's very important to have a minimal prior testing, and never IUI without a minimum of prior testing. No IUI without monitoring stimulation, because it's waste chances for the patients. The normal protocol, I think it's the protocol with RFSH or SMH. It's like you want. You begin at day 3 to day 8 with 50 units, and you can go up to 100 units if you want. And you have echography and hormonal levels at day 9, and sometimes you need it to according your treatment. and after you're triggering with HCG between day 9 or day 11. A variant can be proposed to the highly responsive woman, but not PCOS. By beginning on day 6, the idea is to maintain the dominant follicle and possibly to develop a second without more. It is possible to do an injection every other day, so the patient injects themselves only every 2 days. It's just the main good thing. In case of PCOS, you have several protocols. First of all, step up, where you increase the dose every 7 days until you obtain one follicle greater than 10 millimeter. You see that in the first line. You have step down with begin with a high dose, and once you obtain a follicle, you decrease. So you keep the dominant follicle, and theoretically, the other follicles can no longer increase. And the sequential is like the step-up, but slower. In France, we usually use the chronic low dose. Like the step-up consists in taking time to stimulate, even if we take a follicle. And it's possible to do 1 month, but to be sure of having only one follicle. It is necessary to be patient. And in practice, you begin at day 2 to day 5 with the dose 37.5 or 75 units. First test after 7 days of injection. Results if you have one follicle greater than 10 millimeter. You continue until the triggering. If not, you continue again 1 week, and if not, you up to 25 units by 7 days. For the IVF and ICSI, in IVF stimulation, it is important to control everything. In particular, you want to avoid spontaneous ovulation. So you need to use a system of blocking.
The micro is not functioning anymore.
I don't know. Thank you. So, yes. It's okay. Oh, thank you very much. In particular, so you want to avoid a spontaneous ovulation, and you need a system of blocking. You have 2 choices, GnRH agonist and GnRH antagonist. GnRH agonist is a decapeptide. Its half-life is lengthened because of acid D-amino, which blocks the enzymatic decay, and it is strong attraction to the receptor. The effects works in 2 stages. First step, it is an agonist. Thus, the first effects are a stimulation with release of FSH and LH. It's called flare-up effect. And you can obtain a little stimulation and sometimes a pregnancy. Finally, have a downregulation with a pituitary desensitization. Normally, the peak of LH is under control. You have various forms of agonists. Deposit, 1 injection is enough, and the effects are extended. Daily dose, 1 injection per day, or spray. It's a nasal spray. It's very comfortable for patients. The most treatment used is GnRH agonist daily dose. You begin 7 days before the expectant menstruation, and you continue during 12 to 18 days. And when you obtain the desensitization, you can begin the stimulation. The GnRH agonist deposit, it's just use GnRH deposit one time, and it's the same way the daily dose. You begin 7 days before the expected menstruation, and when you obtain the desensitization, you begin the treatment. You have a short protocol is mainly used for poor responder. The goal is to use at the same time endogenous FSH with the flare-up and exogenous FSH. This protocol has been abandoned by many of us since use of GnRH antagonists. GnRH antagonist, you remember that the GnRH is necessary to introduce the peak of LH, and the GnRH antagonist works immediately, suppresses the positive feedback of estradiol, and prevents the premature or delayed peak of LH. It has a short half-life. The most used the antagonist daily dose can be introduced on fixed day, like 6, or flexible, according to the size of follicles or estradiol levels. These protocols are called fixed or flexible. You use antagonist every day until the day of HCG. Protocol use single high dose was removed in France, in market in France, but it works in one time around day 8 and for 4 days. It is usually enough until the triggering. It decreases the rate of estradiol and LH without disrupting the follicle dominant growth. It could be very interesting in case of risk of OHSS. In certain cases of poor responder or on other hand in good responders, we can use half spontaneous cycle protocol. The goal is to use antagonist and FSH only at the end of the stimulation and to trigger as you want without risk of escape while maintaining the follicle dominant. Any study could say that this protocol is better than a classic protocol. However, it is very interesting in cases where the treatment is at the expense of the patient. However, as you will have noticed, there are multiple advantages in using the antagonist. Why? We could summarize like that. In the meta-analysis, the author show that the multiple advantages: simple prevention of premature peaks of LH, no flare-up effect, no risk of getting a cyst, no period of hypoestrogenic, no risk of beginning the stimulation while the patient is pregnant, duration of ovarian stimulation is shorter, and requires less exogenous gonadotrophin. But 3 reasons for only, I just talk about 3 reasons for that. The first, and it's very funny, is the comfort of patient. Cumulative IVF pregnancy rates are compromised by the large number of couples who drop out of treatment before achieving pregnancy. And in the study of 384 patients undergoing IVF treatment, the incidence of dropout from protocol with either GnRH antagonist or GnRH agonist was evaluated. Cox analysis of the difference in cumulative dropout rates between the two treatment strategies showed difference significative in favor of patients treated in the mid-stimulation and its antagonist arm of the study. The physical and psychological burdens of treatment are the most frequent cause of dropout by women and their partners. Second, in meta-analysis, the authors shows that they have as much OHSAs with the same live birth weight, so the same efficiency for the less risk. And these authors consider this treatment like a primary prevention of OHSAs. And they said every 55 women treated with agonists instead of the antagonist equal 1 woman hospitalized for OHSAs. Third, possible triggering by agonists. GnRH antagonists move the antagonist of receptor, and the advantage is less or no OHSS. And it's very comfortable now because we have vitrification, and since vitrification, we have good results in pregnancy with frozen embryo, and it's very easy to triggering the patients with freeze embryos and delay the transfer. So, in IVF antagonists contributes for the main results: patient's comfort, less FSH, less risk of OHSAs, possibility of triggering by agonist, pre-treatment efficiency, and avoiding weekends. Thus, it concerns normal responder, but for them, all is okay. you could use what you want. Poor responders, because you have slowed down ovaries less. Prevention of OHSS in PCOS patients. And treatment shorter and less strong in endometriosis patients. So the criteria of choice for a treatment are age, ovarian reserve, causes of the infertility, number of previous attempts, results of the previous treatments. You could choose the kind of desensitization, the kind of gonadotrophins, and the dose, depending on the first 3 criteria for a first treatment, and all 5 criteria for following treatment. If I can just sum up the main points, the take-home messages are first choice according to age, ovarian reserve with blood tests and or antral follicle count. In particular for the choice of doses of gonadotrophins, and to avoid complications. Always reflects on reasons for failure. Is the method the right one? Is the treatment a good one? It's very disappointing to see that certain practitioners never change their treatments and adjust according to previous stimulation. Thank you for your attention.